Так, ну сьогодні я з великим задоволенням хочу представити і можу з гордістю сказати, що можу представити свого вчителя Макса Вольфа, який являється не тільки психологом і психотерапевтом, а ще й науковцем. Тобто в нього така крос спеціальність, яка мені здається дуже важлива. І не тільки в сфері психотерапії, але також і в сфері психоделічної науки. Е, Макс Вольф працював у декількох клінічних випробуваннях як психолог, психотерапевт. Ви вже, можливо, знаєте, чули про епізод стадії, який було проведено в Німеччині. Це фаза 2 клінічного дослідження з псилоцибіном для лікування резистентної депресії. Також у Макса є досвід роботи в клінічних дослідженнях із іншими речовинами. Він активно займається розвитком програм, навчальних програм для спеціалістів у сфері психоделічної терапії. І якраз очолював розробку програми Augmented Psychotherapy Training від Mind Foundation, в якій я теж навчалася. І завдяки саме Максу я взагалі більш глибоко занурилася в тему психоделічної терапії, як саме феномену психотерапії, тобто де психоделічна речовина не просто щось, що ми використовуємо як медицинські, да, як речовину для лікування депресії, а речовина, яка вбудована саме в психотерапевтичний процес. І сьогодні Макс якраз буде вибудовувати оцей місточок між психотерапією і дослідженнями, і на основі психотерапевтичної моделі змін Граве він розкаже, як саме психотерапія грає роль в лікуванні депресії за допомогою речовин. І після презентації у нас буде можливість задати питання. Я думаю, що Макс буде сьогодні згадувати свої публікації, тому що їх у нього дуже багато. Він теж із командою з інших науковців розробив 2 опитувальника, які, я вважаю, і наші майбутні науковці будуть в майбутньому використовувати в дослідженнях, тому що інструментарію, на жаль, поки не так багато для досліджень саме психоделічної теми. І я думаю, що якраз те, що він сьогодні буде згадувати, я тоді буду посилання на ті статті, які є в відкритому доступі, я буду тоді давати в чаті, щоб ви могли теж ознайомитися. То передаю слово Максу. Дуже дякую за твій час сьогодні. Такий предріздвяний вечір, да, майже, що ти виділив цей час для нас, і ми з задоволенням будемо слухати твою лекцію.
Thank you very much, Ina. Thank you for the very kind introduction. Thanks for inviting me here tonight. It's a real honor. It's a real pleasure to have this opportunity to talk to you today. I think you're a special community, and yeah, I'm already impressed by simultaneous translation and things like that. Please let me know if I speak too fast or too slow, or if you have any questions, you can always interrupt me. And we're also not such a lot of people, so we can also, if you want, you can ask questions, and we can make it a bit more interactive. I don't have to talk for 1 hour straight. I can if you want, but we can also have a conversation. So I'm going to share my screen. Let's see.
When you share, there is a
Yes.
request. Yeah.
I don't think I have the option. Ah, yes, I do. Okay, yes.
Mm-hmm.
Yeah. So I think I requested it.
Yes, I gave you the permission. You can maybe start again or
Ah,
try to
yeah.
start
Ah,
again.
yeah. Okay, yeah. This works. Okay.
Mm-hmm. Yes, we can see it. Mm-hmm.
Can you see this?
Yes, yes,
Good.
perfect.
Okay. So I will not see you a lot because I have a small screen only. So if you want to
Мгм.
ask something, just say something because I will not see you raising your hands. So
Да,
yeah, this.
давайте так, да, що якщо буде
Yeah,
питання, піднімайте ручку, щоб ми побачили, що є питання.
yeah. Okay. Yeah. So yeah, this will be a theoretical talk. It will be actually a lot of theory. I hope it will not be boring. I hope we can make connections to the practice also. Yeah, and although it's theoretical, I imagine it to inspire your work also, your practical work, with or without psychedelics, because this is a talk that's not only about psychedelic therapy, but it's also about psychotherapy in general. What is psychotherapy? What do different types of psychotherapy have in common? Um, and this also includes psychedelic therapy, of course. Yeah. So what do I want to do today? I want to propose a psychotherapeutic understanding of psychedelic therapy, one that is comprehensive, yeah, one that can explain a lot of phenomena and a lot of empirical findings from psychedelic research. It should be integrative. That means it should not be based on just CBT or psychoanalysis or systemic therapy, but rather uh, build on empirically based general models of psychotherapy, yeah, that are transtheoretical, and it should be useful. Yeah, it should be an understanding that can inform research questions, and that can also really inform your therapeutic work. Yeah, how to prepare patients, how to um, guide dosing sessions, how to integrate psychedelic experiences, and so on. And I will do this based on two theoretical frameworks that I will present. And these frameworks you can read if you're interested. A lot of what I'll say today is explained more in detail in this recent paper here. Um, it's a long paper. It's the longest paper I ever wrote. Very difficult to find a journal that will publish such a long paper. Yeah. And then I don't know if we have time for this, yeah. But if we have time in the end, we can also have a bit of a discussion on how psychedelic therapy should be studied and regulated, because I believe understanding psychedelic therapy as psychotherapy, it has consequences also for regulation of psychedelics, psychedelic drugs. Yeah, Ina, I think you will post the links to the papers. I also have on my slides. I also have on the last slide. I also have a references list. So this is the first model I will show you, and it's um, a bit of the basis of what I will talk about today. This is not the whole model, yeah, that would be too simple. But we'll build it up slowly. Yeah? So this model has two basic assumptions. The first assumption is that the longer term effects of psychedelic drugs are substantially mediated by the acute psychedelic experience. This is the horizontal arrows here. Yeah? So this is actually a very well-established finding in psychedelic research that the psychedelic experience predicts longer-term outcomes. Yeah, it's important. It's not a side effect or so. And the second assumption is that the acute and the longer-term effects, they are substantially moderated by context factors. This is also a bit trivial if you know about psychedelics. Of course, we know that psychedelic experiences are strongly dependent on things like set and setting, yeah, your expectations, your wishes and fears, motives, ideas, your current mood, and so on. And we distinguish. I think it's practical to distinguish an immediate context, that what is going on during the experience itself, from a superordinate context. Yeah, that's a more kind of enduring factor. Things like the personality, the disorder that somebody brings with, but also their cultural background, their childhood. Also things like an ongoing psychotherapy process. Yeah, that's also part of the superordinate context. Yeah, so this is a very actually quite a simple model. It's not too complex. And I will propose that the role of psychotherapy, or if you want to call it psychological support, is to purposefully shape a context that promotes therapeutically valuable psychedelic experiences and promotes their beneficial longer term integration. Yeah. Very simple idea, actually. Yeah. So today I will focus mostly on the centerpiece of this model, on the psychedelic experience itself. Yeah. So what types of psychedelic experiences are therapeutically valuable? Yeah. I think it's important to have a broad understanding of that. We should not focus on specific subtypes of experiences only. Yeah, this is always a danger in any psychotherapy that people have a too narrow idea of what is useful and what are valuable experiences. And I want to invite you to broaden the horizon. Yeah? And um, this is what we will do today. So these little symbols here, Inna, you know them well. You've seen them a lot. Yeah, this is a little picture. I will zoom in a little bit more. This is the general change mechanisms, yeah, that I will talk about, and I already proposed that they play a role not only during the psychedelic experience itself, but also in the preparation, in the integration phase. Yeah? And I think the new thing here is to really look at psychedelic therapy or the different phases of psychedelic therapy, preparation, dosing sessions, integration, with the same theoretical lens. So we use the same theoretical constructs to understand what is going on in these places. So let's talk about psychotherapy. Yeah? So if you look at this, all these different psychotherapy schools, um, it seems like they're quite different. Yeah, we have things like yeah, CBT, schema therapy, psychoanalysis, gestalt therapy, family therapy, and then also non-verbal things. Yeah, body psychotherapy, music therapy. Superficially, these are very different types of psychotherapy, but there is a long tradition in psychotherapy research that assumes that what is actually working, yeah, what is effective in these therapies is are common factors, things that the different therapies have in common. Yeah? This is already almost 100 years old, the idea of common factors. There are many different words for common factors. Are many different models that have been proposed. They're not really competing models. Yeah? I think they're all look at the same thing from different perspective. I will focus on this one model here, the model of general change mechanisms by Grawe. Um, this is the picture you saw before. These are the five change mechanisms proposed by Grawe. It's an empirically established model. In the 1990s, Klaus Grawe did a meta-analysis of 1,000, roughly 1,000 psychotherapy studies and identified across therapies and across modalities these five um, change mechanisms. And the reason why I choose this model, also as a model for teaching psychedelic therapy, is that it describes, first of all, it describes therapeutic experiences. Yeah? It describes what kinds of experiences occur in effective psychotherapy. It also describes the associated change processes, what is going on psychologically um, during and after such therapeutic experiences. And it also can be used to classify therapeutic interventions. Yeah? So we can speak about, for example, a resource activating experience that somebody has, maybe in everyday life or in psychotherapy or in psychedelic therapy. And we could also speak of a resource activating intervention or a resource activating um, thing that I do with a patient. Yeah? So it's very useful also practically to have such a classification that connects experiences with interventions. We have also developed a questionnaire to measure these general change mechanisms in psychedelic therapy. Why is this necessary? There are many, or at least some questionnaires already available, of course, to measure these change processes in conventional psychotherapy. But if you look at the items, yeah, for example, let's look at this item here. Today, the therapist touched my vulnerable spots. Yeah, this is an item to measure this process here, problem actuation. Yeah. Um, if you look at that item, it doesn't really work in psychedelic therapy, yeah, because it assumes that the therapist is doing the work and that the patient is attributing the experience to the therapist. And in psychedelic therapy, that's not always the case, of course, yeah? Especially during psychedelic experiences. A patient may have for example, a problem actuating experience, but they may not necessarily attribute that experience to the therapist. They may attribute it to, for example, the substance or some entity that they met in the experience, or to themselves, or to whatever. Yeah. So for psychedelic research, we have to formulate these items um, more broadly. There is a mistake in here. It should say, I could feel that my vulnerable spots were being touched upon. Yeah. So this is leaves much more open. Yeah. The question of who did this. Yeah. It could be the therapist, but it could also be something else. Yeah. So this is the idea for this questionnaire. We validated it in a large survey in English and German at once. Um, I will not go into too much methodological details now. I will just go through all the different change mechanisms, and to illustrate what they are, I also will show the items, yeah, that we use in this questionnaire to measure these processes. So resource activation. I could see myself in a positive light. I became aware of things that I'm thankful for. I felt connected to things that give my life meaning, and so on. So, what are we measuring here? Yeah? Um, Here is a definition. Activate adaptive capacities. Yeah? We have to activate that which is not problematic about the patient or the person. That what actually works. That is that which is um, positive attributes, functional attributes of the person. Um, Adaptive capacities to pursue positive motives that serve the basic psychological needs. Yeah, needs such as orientation, control, attachment, pleasure, and self-esteem. This is a very classical common factor in psychotherapy. Um, it's not what lay people usually assume what psychotherapy does. Yeah? Lay people often assume that psychotherapy is mostly about problems, yeah, and it's understanding your problems and changing your problems and finding new ways to cope with your problems. And that's also true, but there has to be also this focus on resources. Yeah, if there's only problems, then you cannot change the problems. Yeah. So what are resources? Any functional capacity that a person has. It can be motives, positive goals, intentions, plans, values. Yeah. Think about your patients and think about their resources. Think about the positive wishes they have as resources that you can activate and that you can use in therapy. Abilities, personal strengths, skills, knowledge, wisdom, intelligence, and so on. You can think of these also as sometimes as capacities that are currently not being used. Yeah? Very often we have a patient in front of us who has tremendous abilities, yeah, that they're not using. Yeah? And they may not even remember that they have this. And this is our task in any therapy, whether or not we use psychedelics or not, is to get the patient again in contact with these abilities. Positive roles and relationships. Maybe there is a functional marriage or partnership, family, and so on, but also all other kinds of experiences. Then economic strength also, yeah, having money, having status, having specific roles or work. Physical strength also, yeah, health, favorable physical attributes, attractiveness, all of that, yeah. It's a resources are an extremely large, broad construct, yeah. And I think it's very important for psychotherapists to become really good at identifying your patient's resources, yeah, and get them in touch with resources. Why is it important? Well, we know from psychotherapy research that focusing one-sidedly only on problems uh, is an ineffective strategy. Yeah, the patient will see themselves as only problematic, and they will not be motivated to change. Effective therapies focus on resources, especially in the beginning, yeah, and the patient must see themselves as more than the sum of the problems. So there has to be this balance here, yeah, between the resources and the problems in therapy. Now, let's look on, before we go to the problem side, let's look at psychedelic therapy. So these are three results from psychedelic research. Mystical experience, yeah? Mystical experiences, perhaps the most commonly used construct in psychedelic research, and it's a very potent predictor of therapy outcomes. Yeah, this is here a study. I don't know if you can see my cursor. Yeah, this is a study with smokers. Yeah, the more mystical experience, the less they smoke. Or the less they have craving. This is with depression, and this is with anxiety in people with patients with cancer. Uh, it's an extremely strong predictor, and I will make the argument that mystical experiences or the therapeutic value of mystical experiences lies, from a psychotherapeutic perspective, primarily in resource activation. Yeah. So let's look at a qualitative example from a study. This is a study with healthy volunteers, but I think it could also, the same experience could also be reported by by a patient in psychedelic therapy. So I will read this, yeah, so that you can translate it. So this is a patient who had a high dose of psilocybin in a study setting, and later they're interviewed and they tell the interviewer this. The feeling of joy and love was the energy in the universe, completely intense and multiplied by 100. It was like taking those two emotions and concentrating them to have them in their purest form without any worries or other troubles that can come with everyday reality. Everything else ceased to matter while those two emotions were so pure. They made everything incredibly beautiful. When I was soaring through the sound waves with this energy, I could see all the people close to me in my life appear. My partner, my sister and her boyfriend and their newborn son, my mother, my amazing friends. I felt immensely privileged to be part of this universe, of this community, to be able to feel those feelings in such a pure form and to have such deep emotions in my body. And I was overwhelmed with gratitude for this world, that everything simply is. And with that, I was overtaken by a desire to protect it all, to show the world how beautiful it is and to take care of it. Yeah. Um, so this is a patient who also completed the mystical experience questionnaire. And it's a bit funny that in the mystical experience questionnaire, there is a cutoff value. Researchers have defined a value. If you have a certain score on this questionnaire, then it will be classified as a complete mystical experience. I think this is a bit funny, and from a scientific perspective, a bit nonsensical. But it's important here, yeah, to realize that this report is quite typical for a person who has a high score on the mystical experience questionnaire. And let's have a look at it, yeah, through a psychological lens. So we have a transient inactivation of avoidance-related mental activity. Yeah, so there's not a trace of negative emotions. Everything is positive. Yeah, the person becomes purely approach motivated. There are intense positive emotions. There is this deep fulfillment of the basic psychological needs. Yeah, if you look closely at this quote, you will identify that a need also for orientation and control is being satisfied. Yeah, the person is um, saying things like everything else seemed to matter. Yeah, this all made sense. Yeah. Then there is attachment, of course. Yeah, the person is speaking about their actual relationships to significant people in their life. Pleasure is very obvious. And also, if you read closely or hear closely, there's a self-esteem. Yeah, there is something about feeling privileged to be part of this community and so on. Yeah, so it's really an appeal to um, the full spectrum of the basic psychological needs. Yeah, and they're deeply satisfied in this experience. And what happens when people have need-satisfying experiences? They they develop approach schemas, yeah, and positive goals, new positive motives. Yeah, this is the end of the quote. With that, I was overtaken by a desire to protect it all, to show the world how beautiful it is, and to take care of it. So it's not just a mystical experience that's taking place somewhere in the universe, yeah, and it's disconnected from reality, but it's really what the patient is, or what the person is taking away from it is a new motivation, yeah, to change something in the world, yeah, something that they find value in or meaning, positive meaning. Yeah? And in my opinion, this is the psychotherapeutic mechanism by which mystical experiences have psychotherapeutic effects, because they strengthen people's positive goals and approach schemas. But resource activating psychedelic experiences are also not always mystical. I think mystical experiences are only one subset of psychedelic experiences. And they're also, the resource activating psychedelics, they're also not always purely positive. They very often connect the resources with the problems, which is something that we as therapists also need to do. Yeah? We also always need to, yeah, between the resources and the problems. Here is another quote from a patient that we treated in the episode trial. The episode trial is a psilocybin study that we did in Germany for people with treatment-resistant depression. Uh, I will read this quote as well. I saw my true self, the person that I really am, that I'm actually an active person. I like to move. I like to be loud sometimes, not always just this holding back and being quiet. I actually like to do things and be with other people. I always thought I was just a person who prefers to be alone. And that's not necessarily the case. I'm also not as cold and heartless as people might think. I'm more of a warm person deep down. I'm actually a person who just likes to make shenanigans or play around. I've always just suppressed that. And now I'm trying to learn to allow it. Yeah. Um, I think this is a very beautiful quote, yeah, because it you can feel the resources, yeah, when you hear it. You can you get an idea of what a likable person this is, yeah, and uh, as a psychotherapist, hearing something like that is just very touching, yeah, because it seems like this is a self-image that the person has apparently lost touch with, yeah, for probably for a long time. And in this experience, they somehow found a way to reconnect, yeah, with this part of the self. And here, the last sentence, I put this in bold because you can see how it changes the motivation. Yeah, the person saying, I've always suppressed that part of myself. Now I'm trying to learn to allow it. So this is a motivation to work, yeah, and to change something. It's not automatic, yeah, but this experience motivates the patient to change something about their problems. Yeah. And as you can probably tell from the quote, it's a patient with not only depression but also um, with a severe social phobia. Yeah. They get very anxious in social situations, and it's hard work for them, yeah, to go out and show this other part of themselves. Yeah. And this resource activating experience has made them um, more motivated, yeah, to work on that and to change. Here's another one. Patient with a person with an eating disorder from an ayahuasca experience. I saw myself as a rotting, decaying skeleton, and then I saw myself as this beautiful, full-bodied, beautiful woman with this long hair, and I wanted to be that woman. I wanted to be that full, loving woman that has so much to offer my family and world. And then I felt my ribs and I could feel them, and they were so hollow, and I was just like, I can't wait to get back and just start gaining some weight. So it's the same pattern, yeah, that we see here. There is a positive image. The person discovers something about themselves, develops a wish. Um, I think in this case, it's not really. It seems like it's not only about physical properties and being a beautiful woman, but it's also about being a nurturing, loving person again. Yeah? And this seems to build a motivation to change, and in this case, to work on an eating disorder, to start gaining weight again. Yeah. Um, Something important here. I think these two examples, they illustrate very well that, well, these experiences are therapeutically very valuable, and at the same time, that's not the end of the therapy. Yeah? You can see how um, in the integration phase after experiences like that, we should really help the patient make the best out of these experiences. It's really still difficult what they're trying to change. Yeah? And they, in many cases, they can do without support, but in many cases also they need really active support to grow these new motives into more stable approach schemas. Yeah. Well, this I will just, well, I will not skip. I will say a few words. I will not go into the quote again, but of course, in integration, what we need to do is we need to reactivate the resources that have been activated in the experience. We need to help the patient have similar need satisfying experiences in everyday life, without um, um, a pharmacological intervention. Yeah, need satisfying experiences. And we also need to work on competing avoidance motives. We need to reduce avoidance motives in order to strengthen the approach schemas. Yeah? And that's where the problem side comes in. Yeah? So just coming back to this model, I've shown you a few resource activating experiences. I will hypothesize that these are most likely to happen when you already activate a patient's resources in the preparatory phase successfully. And they're also probably more helpful when you activate the same resources in the integration phase. Yeah. A very simple idea. Yeah. So what to take away from this? Watch out for when your patients tell you about their psychedelic experiences, watch out for resources. Yeah. Identify the resources that have been activated and find ways to reactivate them later. Well, okay, let's move to the problem side. Yeah, that's maybe a more stereotypical idea of psychotherapy. Yeah, that we work on problems. Yeah, and it's of course it's also necessary. So problem actuation. I relived painful or fearful memories. I experienced feelings that I previously avoided. I was confronted with my problems. This is the vulnerable spots thing. Yeah, could feel that my vulnerable spots were being touched. I felt emotions that are related to my problems. So this is about fully experiencing emotions that one would otherwise avoid. Yeah? Has to happen in every successful psychotherapy. So in psychedelic therapy, yeah, there is a construct that's related, sort of related, but not strongly related. You may have heard of this challenging experience. Yeah? This is a construct that is developed in psychedelic research. They found this more scientific word for the colloquial kind of bad trip, you can say. And this is really, it's a good tool to describe the form of a difficult experience that somebody has. It has several subscales. You can really identify different types of stressful experiences, but it's not a good predictor of change. Yeah, the challenging experience is neither a positive nor a negative predictor of longer term change. Here is just an example, yeah, from a study that found no association between challenging experiences and longer term outcomes. And if you think about the construct, it's very clear, yeah, why this is the case. And based on the model that I'm presenting today, I think this is the important thing to realize, that challenging experiences, they can be problem actuating. Yeah? They can be experiences that have to do with the patient's problems, but they can also be, yeah, this is this part here of the diagram, they can also be just terrible experiences. Yeah? And that doesn't have necessarily to do, yeah, with the person's psychological challenges that they face in everyday life. And also, on the other hand, not all problem actuating experiences are necessarily very challenging. Yeah. So if you're working on a problem, or um, if you're looking at a difficulty that you have, it's not necessarily an overwhelmingly negative experience. For example, if you're able to look openly and accept the problem, yeah, as it is, yeah, then it's usually not such a challenging thing. So in summary, yeah, this challenging experience construct, it's not a very psychotherapeutic construct. Yeah? It's interesting, but it's not informative regarding psychotherapeutic processes. In order to really capture the therapeutic quality of challenging experiences, you have to add other components. Yeah. So problem actuating experiences, they have to be combined with corrective experiences. Yeah. It's not enough to just face your problems or to just experience your feelings. You also have to learn something from it. Yeah. For example, gain self-understanding, which is the change mechanism of clarification that I will talk about in a second. Or you learn a new coping strategy. Yeah, that's what we would refer to as mastery. Here is a, a measure, the emotional breakthrough inventory, just a very brief measure that combines those three things, yeah, problem actuation, clarification, and mastery. Yeah. It's a broad measure of the kind of the problem-related side of psychedelic therapy. And this is just an example, yeah, from a study that found emotional breakthrough experiences to strongly predict reduced depression. What do we have here? Yes. Okay. Let's look at the first type of corrective experience, clarification. So I gained a new understanding of the difficulties in my life. It became clearer to me why I tend to react in certain ways to difficult situations. Became clearer to me what the essence of my problems is. I could see my problems in a new light and so on. So this is about gaining self-understanding, yeah, from an experience, gaining awareness of previously unconscious emotional patterns and learning to recognize, understand, and question them. What is clarification? So I think I will not go too much into this, a bit too detailed. Let's talk about insights. Yeah. So in psychedelic therapy, people talk a lot about insights, and insights. Mm, I think we need differentiation. Yeah. So this is an interesting study. They reviewed almost 100 intervention and survey studies, and they found that insights are, first of all, psychedelics seem to induce insights. Yeah. So in almost all studies that had a control condition and tested it against a psychedelic, the psychedelic um, um, increased rates of insight. Yeah. Also, most studies find that insight is associated with therapeutic outcomes. Yeah? In this case, for example, psychological insight, it predicts changes in rumination, yeah, in depression patients. But let's take a closer look, yeah, because not all insights are clarification experiences. So, for example, some insights are not psychological insights at all. Yeah? So one of the most commonly used scales in psychedelic research, the altered states of consciousness rating scale, has an insightfulness subscale. And it's really about all kinds of insights. I gained clarity into connections that puzzled me before. That could be anything. It could be maybe the insight about the taste of tomatoes or something like that. Yeah, which can be interesting, but it's usually not therapeutically, or let's say in some cases maybe it can be, but it's not necessarily a therapeutic insight. So we have to look at a subset of insights. This is a psychological insight. Um, we have a scale here, the psychological insight scale, that measures these, yeah, with items such as I became more conscious of aspects of myself that I used to ignore or not be fully aware of. So here we're getting closer to the psychological stuff. And then you can distinguish also between insights related to resources and insights related to clarification. Yeah. So some insights are like the one I showed before about the patient with social phobia. This is a strength I have. This is a positive quality. Yeah? This is more about resource activation. And then there are clarification related insights where people learn something about their problems. Yeah. This I will go over also. Yeah. Mastery. I made progress in coping with my problems. I learned things that can help me handle difficult situations. I gained confidence in my ability to handle strong feelings. So this change mechanism is more about learning new abilities, yeah? um, for handling unpleasant feelings and for also handling challenging situations. Yeah. This is very theoretical. I will go over it. If you look at standard psychotherapy, you can find many different interventions, yeah, that all have the purpose of inducing mastery experiences. Yeah, you can have assertiveness training, yeah, teaching people how to be in an argument with someone else, yeah, for example, yeah, that can lead to mastery experiences. Things like biofeedback, yeah, controlling your blood pressure, yeah. Um, things to regulate your nervous system. Things like learning to observe your thoughts rather than reacting to them. Yeah. Disputing your own thoughts, like in CBT, yeah, or using sports, yeah, to manage difficult situations. Peer exposure, yeah. So I'm just showing this as an incomplete list. There's a lot of mastery related experiences. And I think in psychedelic therapy, like I said before, with resource activating experiences, it's very useful to when you have an integration session and your patient tells you about their experience, to pay very close attention to um, mastery experiences. Yeah, what did they learn? Yeah, what kind of new ways to cope with difficult feelings or situations did they um, discover in the experience? So here is a result from a study that compared psilocybin against escitalopram, so an SSRI antidepressant. And this is in the supplementary results. The strongest difference between psilocybin and escitalopram was found for avoidance. So psilocybin specifically seems to reduce avoidant coping strategies. So this seems to be a very distinctive um, um, property of psychedelics compared to standard antidepressants. And I think this is a strong signal, yeah, that people have mastery experiences. Yeah? Mastery experiences that reduce avoidant coping strategies. Let's look at a few examples. Yeah, this is a very recommendable paper by Rosalind Watts. Oh, yes. Hi, Artem. Yes.
Є. Макс, а чи можна повернутися на попередній слайд І в мене
This one?
питання стосовно шкали Suicidality. Там майже вони, так,
Mhm.
вони поряд. Цікаво, чи міг би ти прокоментувати, якщо можливо. Дякую.
Right. So this graphic here, this figure, it shows all the secondary measures. This is the first measure of the study. The QIDS, it's a depression rating scale, and it's not significant, the difference. Yeah. So in this study, actually, depression was not a difference after, I think, 6 weeks, but all the other things were different in favor of psilocybin. Suicidality actually was also significantly different in favor of psilocybin, but it's one of the weaker differences. Yeah, it's not a strong difference. Yeah, so people after psilocybin, patients after psilocybin compared to escitalopram, they were less suicidal, but not much less. Any more question about that? Um, Yeah, good question. I will come there now. Yeah, so what's happening? Yeah, with psilocybin? How does it reduce avoidance? That's actually one of my core research focuses. Yeah, so let's look at these experiences. For example, yeah, they explain. I think they really explain what is going on. So here's a patient talking about their psilocybin experience. This paper is a qualitative paper. It's very, very recommended. Um, Patient is talking about their psilocybin experience. There was this huge, terrifying creature with a rifle, and instead of running away, I looked at it, and it wasn't as scary as it had seemed. My fear subsided. It suddenly seemed ridiculous. I started laughing. If I had avoided it, it would have gotten more terrifying. Yeah. So very interesting experience. Yeah. The patient has apparently learned something here. Yeah. If I had avoided it, it would have got more terrifying. So they had an experience that rewarded acceptance, and it would have punished, if you use behavioral language, yeah, it would have punished um, avoidance. So apparently the patient has learned here something about how to navigate psychedelic experience. Yeah. When you look the monster in the eye, yeah, or when you go to the monster with the rifle and look at it, it becomes less threatening. Yeah. And when you run away from it, it becomes more terrifying. Yeah. And that can be, I think this is quite a universal experience, yeah, that people have in different forms and shapes. Um, and I believe it can be, under favorable circumstances, it can be a conditioning process, operant conditioning process that strengthens approach behavior and weakens avoidance or avoidant coping. Yeah. Here's another one. I had an encounter with a being with a strong feeling that that was myself, telling me it's all right. I don't need to be sorry for all the things I've done. I had an experience of tenderness towards myself. During that experience, there was a feeling of true compassion I had never felt before. Yeah. So the construct here, the psychological construct here is self-compassion. Yeah. Something that is, well, something we try to model, yeah, in psychotherapy with patients, and something that is really, really hard for many patients to even experience in the slightest sense. Yeah. And here suddenly sometimes they can have this full-blown experience of self-compassion. Yeah. So these are maybe related mechanisms. Yeah. Self-criticism towards self-compassion, judging towards observing or mindfulness, avoidance towards acceptance. Here's the model. So this model would be my response to your question. So how does it work? The reduction of avoidance through psilocybin or other psychedelics. This is a model we describe in this paper, learning to let go. And well, the basic assumption is you can learn acceptance in a psychedelic state or from a psychedelic state. And something like operant conditioning is going on. Yeah, the more you avoid, the more distress you will experience. And once you learn to desist from your avoidance strategies, to let go, then you will often experience immediate relief, and that can act as a kind of a negative reinforcement, a reward, and under favorable circumstances, people can have these experiences that really change the way that they cope with negative experiences or negative emotions. So we also developed another questionnaire to measure these experiences, avoidance-related experiences and acceptance-related experiences. I don't want to go too much into the details, but I just want to say that these are two broad facets, acceptance and avoidance, and you can look at different sub-aspects. So people can have accepting responses or avoidant responses. They can feel relieved or distressed. And they can have acceptance-related insights, such as, oh, I can really look at these painful memories or these monsters or so, and it's okay, and people can also, under less favorable circumstances, have avoidance insights, things like, oh, it's really dangerous to look at my emotions. They are really these monsters with the rifles. They're really kind of dangerous, and I should avoid them. That can also happen. Okay, so here we developed this questionnaire, and we also used this questionnaire to measure avoidance and acceptance experiences in the episode study. This is the episode study timeline. There were 2 dosing sessions, and after each dosing session, the patients received this questionnaire so that we can measure avoidance and acceptance experiences, similar to the ones that I just read to you. And we also measured experiential avoidance as a psychological trait. And we measure how it changes throughout the course of the therapy, at baseline, and then we look at it after the dosing sessions and 6 weeks after, and even a year after. We measured this experiential avoidance. And as you can see, this is actually a focus of the talk. So we will talk about acceptance promoting experiences. So let's look at what happens with placebo. People do not get any psilocybin. It's a blinded study. Maybe some people think they got psilocybin, but what you can see here, you have avoidance on the x-axis and acceptance on the y-axis. You can see that most people, are down here in the corner. That means not a lot of avoidance and not a lot of acceptance. It's kind of unspectacular. Not surprising because they didn't get psilocybin. But some people you can also see here. So there is a person in a placebo condition who had a profoundly acceptance-related experience. So that also happens. And that's interesting, because people, they lie down for 6 hours with music and they're prepared for this experience. There are 2 therapists in the room. For some people, that's enough, to have a therapeutic experience. This is 5 milligram. This is actually this would be considered not a microdose, but a mini dose. Most people notice something, but it's not really quite a full-blown psychedelic experience. And you can see here that both scales increase a bit. So you get more variability on both scales. And then here, the full dose of psilocybin, you see this beautiful scatter plot. So we have some people still, not much acceptance, not much avoidance, but a lot of people have strongly acceptance-related experiences. And also a lot of people have difficult avoidance-related experiences. Not so much here on the extreme end. So there's not a lot of people with extreme scores here, which I believe is a good sign. It tells us that the therapy we did was kind of okay. We provided a safe setting, and when people were in distress, we kind of helped them. Yes, Artem.
Yeah. Mm-hmm.
Так, дякую. В мене питання якраз стосовно останньої повноцінної дози. Так? На графіку там ми бачимо статистичний розподіл по клієнтам, пацієнтам, якщо це в клінічному сеттингу, які отримали, так? І це кількісні значення. Але мені от ще цікаво, чи проводили з ними в рамках, наприклад, цього дослідження якісні інтерв'ю для того, щоб зрозуміти, що безпосередньо відбувалося в людини, да, які показали там низький рівень прийняття після повноцінного дозування, щоб зрозуміти більш людський контекст і суб'єктивний контекст, і потім його співставити вже з статистичними даними. Дякую.
Mm. Well, that's a wonderful research idea. It's actually something that we're starting to do now. Yeah. So most patients were interviewed after the study. Not all of them, but most. This is 144 patients, and I think about 90 patients or so were interviewed. And well, we have these quantitative measures, and you can look at what do these people say, yeah, and what is this experience like, yeah. That's very interesting, of course, yeah. And I think qualitative research is a bit undervalued in modern psychology and psychotherapy research, and especially in psychiatry. Yeah? But we can learn a lot from it, yeah? And that's what we are trying to do here also. But I cannot show you any systematic results yet from that study. But it's something that we're starting to do. Something that you can also see here is that there's no correlation. Yeah? So avoidance and acceptance are not correlated. Yeah? So that's completely insignificant. And that could be counterintuitive. Some people may assume that, oh, well, if you have a lot of acceptance, that means you have very little avoidance, or vice versa. Yeah? But that's not the case. Yeah? You can have both, or nothing of both of them. Yeah? Yeah, it's important. Yeah? So let's look at the time course of experiential avoidance. Yeah, this is the trait measure of experiential avoidance over the course of the study. We have 4 study arms. The blue lines here are those who receive placebo or just a small dose. And as you can see, not much changes here. Yeah? And the orange and red lines are those who have the high dose here. And as you can see, 7 days later, there's this significant drop, yeah, in experiential avoidance. And then a few weeks later, 6 weeks later, everybody, or those who didn't have psilocybin, who didn't have the big dose, get the big dose. And then you can also see a drop here. And in the end, after 6 weeks, after the second dose, it's interesting, yeah, that you hear the order of groups is exactly arranged by the full amount of psilocybin that people received. And those who got most psilocybin have the lowest experiential avoidance. So this tells us, well, it works, yeah? Psilocybin reduces experiential avoidance, apparently. And here now we look at the
Sorry, Max, there is
yes.
a question from
Yes,
Katerina,
please.
maybe it's related to the previously.
Yeah, my question is, what do you mean under experiential avoidance? If I may ask. Could you please explain this term?
Yeah. Oh, yeah, sorry. Good question. Yes. So experiential avoidance, in this context, it means a psychological disposition. Yeah. It's the tendency to avoid unpleasant experiences, or to, you could say, suppress unpleasant experiences. We can measure it with questionnaires. In this case, we measured it with a BEAQ, Brief Experiential Avoidance Questionnaire. The items go like, if there is something that bothers me, I try not to think about it. Yeah? If something makes me afraid, I will do anything to avoid it or so. Yeah? Those are the kinds of items. And it's important to know that experiential avoidance is is a general risk factor for psychopathology, and it's also it plays an important mechanistic role in the maintenance of most mental disorders. Yeah. So if you have an anxiety disorder, then experiential avoidance is actually what keeps you from learning that your fear is not justified. Yeah. For example, that dogs are not actually dangerous. Yeah. If you run away every time that you see one, you will never have the experience that they're kind of cute animals. Yeah. Okay.
Okay,
Yeah.
thank you so much.
So experiential avoidance, yeah, it seems to be something that is affected by psilocybin. Yeah. Vadim?
Так,
Yes.
дякую. Скажіть, будь ласка, Максе, а чи можемо ми віднести уникання 100% до патологічних ознак? Чи, можливо, деякі собаки все ж таки кусають і треба трохи залишати обережності?
Yeah. Yeah. Yes. Very good question. Yeah, it's a very good. Of course not. Yeah. Of course you're right. I mean, avoidance is first and foremost is a very necessary biological function. Yeah. We have to learn to avoid dangers in life. And this is very relevant for psychotherapy. I assume also, especially in a context, for example, of trauma treatment in war, yeah, where people have been traumatized, and you cannot really say that the danger is over, for example. Yeah, this is sometimes very very difficult. Yeah, because uh, having learned to avoid something, it can be a functional thing. Yeah, so that's something to discern. Yeah. Yeah, that's very important to know. Yeah, that avoidance in principle is necessary and important, but it's also important to acknowledge that in most forms of psychological dysfunction, we can find some form of excessive avoidance. Yeah, so when avoidance is so dominant that people, for example, cannot have need-satisfying experiences anymore. Yeah, people cannot leave the house anymore. Yeah, they cannot maintain their relationships. They cannot feed themselves or so. Yeah, that's when I would speak of excessive avoidance. Yeah, and that's I think what we hope to do in psychotherapy and also in psychedelic therapy to reduce experiential avoidance to a healthy level. We don't want to eliminate it, yeah, but to just take away that which is too much. So let's look at the experiences itself. Yeah. So this is the questionnaire that we developed. We can measure acceptance-related experiences. Yeah. An item such as I faced feelings that I previously avoided. Yeah. I confronted a personal fear, something like that, and avoidance-related experience. I tried to run away from difficult memories or feelings, and so on. Yeah? So we measure this, and this model here is a bit too complex. The important thing here is we look at the association between these experiences and the longer-term changes in experiential avoidance. And what we can see here is acceptance-related experiences are what seems to matter. Yeah? The more acceptance somebody experiences during the psilocybin session, the less experiential avoidance they will have 6 weeks after. Yeah? And that's not the case for avoidance-related experiences. It doesn't seem to matter. Yeah? It seems to be completely okay when people have strongly avoidant experiences. Because I think if you think about it, it makes sense. Yeah? Just to have a very avoidant experience, that doesn't mean that you will not also have an acceptance-related experience. For some people, there is this trajectory, yeah, that they first have a very difficult experience, they struggle with it, they fight against it, and then they have maybe this process of learning to let go, and then they find acceptance in the experience. Yeah, so that's one possible trajectory. for other people, it can be like they somehow learn it from the beginning. Yeah, they don't have a terrible, strong, challenging experience, but rather maybe they're well prepared, yeah, or they have a lot of trust in the therapist, and they immediately find that it feels okay and it feels good to look at the difficult things also. Yeah, so there are different ways of finding acceptance. Yeah? But what is important, what seems to be important, is that acceptance is found at some point. So what should we take away from this? We should not rigorously prevent avoidance. Yeah. So I tell my patients, I do not tell my patients things like, you should never run away from the monster. Yeah. If we think in metaphors. Yeah. I wouldn't say that. Yeah. I would rather motivate more kind of an experimental mindset. Yeah. You can say, well, you can try to do that. And you can also see if it works or not. And maybe if it doesn't, you can also try to do something else. Yeah. Play with it. Yeah. That's I think, a better strategy, yeah, than trying to reduce avoidance. Is more to motivate acceptance. Yeah. Okay. Ina, how much time do we have? Not so much, right? I should be very
Yeah,
fast
we
so
don't
that we
have
can.
that much. We
Yeah.
have like 15 minutes. It also depends how much time do you have, because
Yeah.
we can usually extend a little bit, but
Mhm.
you decide
Yeah.
if you can spend a little bit more time for the
Yeah.
questions.
Yeah. I will talk a little bit about the therapeutic relationship still. I don't have much on that, yeah, but I think it's important to talk about it briefly. Yeah. So the therapeutic relationship, of course, it's something that brings together all the other change mechanisms. We can define it as using the positive emotional bond between the patient and the therapist to work on mutually agreed therapeutic goals. Yeah. So we also measure this here, yeah, with this GCMQ scale, and this scale is more about the positive emotional bond. Yeah. I felt safe with my therapists. I could trust my therapists, and so on. Yeah. This is another time I show this. It's a beautiful study. They measured the therapeutic alliance in the preparatory phase, and they find that this predicts rapport on the dosing day, which means this is the emotional quality, yeah, of the therapeutic relationship before dosing. And this predicts emotional breakthrough experiences. Yeah? So this predicts experiences of clarification and of mastery. And this in turn predicts the reduction of depression. Yeah? So we can beautifully see actually our contextual experiential model. Yeah? So this therapeutic alliance is in the superordinate context. And then we have the immediate context. And here we have the psychedelic experience and the longer term outcomes. Yeah. This has been found already in 2 studies with psilocybin, and also an MDMA study, yeah, has shown that the therapeutic alliance is important. And really, I mean, if you're a psychotherapist, this should not come as a surprise, yeah, that this is really important, yeah. But for some people in the psychedelic research, and especially for some industry affiliated researchers, this is an unpleasant reality, yeah, because this takes away the focus from the drug itself. So there are some researchers and some companies that try to minimize the role of the therapeutic relationship. Here, this is an interesting paper, a very short paper. They did a meta-analysis, yeah, and they found psychedelic assisted therapy, the alliance in the psychotherapy component is as important as the drug. Yeah. So they compared the effect sizes and they find that, well, the effect of the therapeutic alliance is as strong as the difference between the drug and the placebo. Yeah. And what is also relevant here is that these guys here, Christoph Flückiger and Bruce Wampold, they are 2 of the world's leading psychotherapy researchers. And this is something I have waited a very long time, yeah, for the people in psychotherapy research to finally pay attention to psychedelics because it's so relevant, yeah, that these guys get involved. Yeah. Artem, yes. You want to ask? Yeah.
В мене якраз в мене питання стосовно дослідження з терапевтичного альянсу. Бо це те, що і мені болить, коли психоделіки намагаються використовувати в медичній моделі. Тобто психоделік, в нього нема прямої фармакологічної дії, як в ліків, там, умовно, ібупрофену, але намагаються його використати в стандартній моделі. Це створює певний якби ризик безпосередньо для людини, людини-клієнта, який в такій терапії приймає участь. У мене питання, чи можеш ти прокоментувати оцей терапевтичний, кореляцію між терапевтичним альянсом і цим рапортом? Як це вплинуло? Чи варто це вже залишити на потім, просто самостійно переглянути це дослідження? Якщо можна коротко прокоментувати. Дякую.
Yeah. So these are just two different measures. Yeah. So this measure is a broader measure of the therapeutic alliance, including not only the emotional bond, but also the agreement on goals and tasks. Yeah. So that's important, of course, an important part of the therapeutic alliance. Yeah. That you agree with the patient what you're here for. Yeah. And what you're not here for. Yeah. And this was measured the day before the dosing session, and the report was just a single item measure. Yeah, and it was this is just about the not so much about the goals and task agreement, but more about the emotional quality. Yeah, so I felt safe with my therapist, or something like that. Yeah, I had a good feeling about my therapist, something like that. Yeah. And this is on the dosing day itself. Yeah, they measured it on the morning before the substance was administered. Yeah, and I agree with you. Yes, there is a danger in minimizing the role of the therapeutic alliance, and this is why this research is so important. I also maybe you can post the link. I had a paper, a commentary 2-3 weeks ago on just about this topic, about the therapeutic alliance. I will find it later and I will put it in the chat.
Okay. Do you mean this is the last paper that
yeah, with
you published?
Kangaslampi. Yeah. With Samuli Kangaslampi, because we invited the Compass Pathways affiliated researchers to actually publish their therapeutic alliance results, because they always say that they don't find a relationship between the therapeutic alliance and the therapeutic outcomes, but they never publish it. Yeah, they just claim it. Yeah, so we're inviting them respectfully to actually publish these results. Yeah, Vadim.
Так, Максе та Артема, я дякую вам за те, що ви на таку важливу складову зараз звертаєте увагу. Та хочу з цього приводу задати запитання. Скажіть, будь ласка, от ми зараз роздивляємося, що є таким дієвим у терапії, чи речовина псилоцибін, чи терапевт, який долучається до цього. А нема розуміння, чи яке саме розуміння є відносно того, яке значення має сам клієнт, якщо ми кажемо про очікування ефективності, бо ми бачили на одному з досліджень, що вони поділяються дуже по своїй реакції на речовину. І, можливо, конституція якась певна дає підґрунтя для того, щоб в одному випадку ми мали можливість очікувати високу ефективність, а при якихось особливостях ми не мали можливості очікувати. Можливо, мова йде про те, що треба якусь шкалу відпрацьовувати, яка дозволить відбирати пацієнтів під цей метод. Дякую.
Right. Yes, so let me go back to this model. This is actually the next slide. So if I frame your question in terms of this slide, you're talking about using predictors from the superordinate context, yeah, person level characteristics, such as let's say baseline avoidance. Yeah, if somebody is completely averse to or not ready, yeah, to work on problems, maybe that's a bad predictor. Yeah, maybe that's a something to work on first. Yeah, before going into an experience. This is just an idea I have. There is quite little research on this, so I think we can derive a lot of hypotheses from what we know from conventional psychotherapy research without psychedelics. We can use this to extrapolate. Yeah, and I think that we should usually assume that the same predictors are effective here. So, for example, if a patient is too distrustful with the therapist, if they cannot trust a therapist, then that is a bad starting position, for example, to have exposure therapy, yeah, with trauma patients or so. First, you need to build trust, yeah, and for me, there's no reason to assume that it should be different in psychedelic therapy. Yeah? We should assume the same things, but there is relatively little empirical research, and there may also be specific predictors for psychedelic therapy. Yeah? And these, I would assume, maybe have not so much to do with the psychological characteristics of the person, but rather with things like neurophysiological dispositions, yeah, brain receptor anomalies, how do you say, metabolic variability, and these things. Yeah, I think those things are specific for psychedelic therapy, and that's also important to look at on the biological level. So we cannot explain everything, yeah, with psychology and psychotherapy, yeah, but we also have to look at the biological side. So this is the model
Max,
that
we have 5 minutes till 7:30.
Yeah, I think I finished. I have one
Yeah.
more slide. Yeah. So this is actually where we started. This is the model. I think I made it clear. We mostly focused here on the experience itself, general change mechanisms, but I hope I made it clear, yeah, that these are important in every aspect of the treatment. So summary conclusion: psychedelic therapy, in my opinion, I hope this was convincing. Works to a very substantial extent through psychological and psychotherapeutic mechanisms. And we can use these two models, yeah, to explain how the acute psychedelic experience interacts with the context to shape clinical outcomes. And the model of general change mechanisms we can use to as an integrative framework, yeah, for understanding how these experiences lead to lasting psychological change. Well, and together, I believe we can use these models to help bridge psychedelic therapy and psychotherapy research. Yeah, these are largely separate fields for historical reasons, also for structural reasons, and we have a lot to win by connecting the dots, yeah, and bringing them closer together. We do not have to reinvent the wheel. Yeah. For psychedelic therapy. We can use a lot of knowledge that we already have from other forms of therapy. Yes, I think these things are more kind of leading us away from the topic again. Let's take 5 minutes for discussion. Yeah. Thank you for your attention. Yeah, sorry for speaking this much. I hope it was okay.
No, it was very valuable for us also to get to know all the grammar theory, because I think it's very new for Ukrainian community, and I think a lot of people will dive deeper. I sent a lot of publications. Also, the last one that you mentioned, I already found it and I sent it in the chat. And we have still a couple of questions. I can use an opportunity to ask my question. if a person like a client would come to you for integration session, usually people experience a lot during 6 hours of dosing sessions. So they bring all the topics that are related
Yeah.
to resources, related to problems and
Yeah.
clarification. How do
Yeah.
you choose in which direction you would go? Do you have preference to first talk about resources and then
Yeah.
later about challenges, or
Mhm.
you go with the
Yeah.
flow, or
Yeah.
which strategy do you use?
Yeah. Yeah. Well, I think the answer must be you already probably predict my answer. It depends very much. But I think before we take the decision on what to focus, yeah, I think it's good to have a basis. Yeah, and I like this model because it's easy, simple enough to have a very relatively simple map, and at the same time it's broad enough to cover all the different types of potentially therapeutically valuable experiences. So what I do in an integration session is I try to get an overview of the whole experience. I don't want to miss anything, and I try to get the overview over the experience, a descriptive overview before really diving deep into an individual topic or so. First, I want to have a let's say a list, yeah, of important potentially therapeutic experiences. And as you said, yeah, it can be a list like in my head, you can imagine resource activating aspects, yeah, and I'd maybe take some notes, yeah. There could have been problem related aspects or clarification related or mastery related. And then I can choose, yeah, what, or let's say, ideally, I can choose together with the patient what to work on first. I like to make that transparent, that decision. But I also, of course, as the therapist, I have my preferences and I can make a suggestion to a patient. So coming back to your question, I think it's usually, this is again another opportunity to learn from conventional psychotherapy research. We don't have to reinvent the wheel. So what do we do in normal psychotherapy? We do not jump into the problem in the first minute of the session. Yeah, first we build a positive mindset together. Yeah, and we build positive motives. Yeah, and then based on that, that's the resource activation. Yeah, and then based on that, we build motivation to focus on the problems. So when a patient, especially early in therapy, let's say they have a first dosing session, they tell me about their experience, and usually there will be bits of everything. Yeah? I will usually focus on the resources first, yeah? Because that's what the patients tend to overlook. Yeah. The other thing is because people think psychotherapy is all about the problems. Yeah. I want to, first of all, I would invite them or ask, so would it be okay to first speak about this? Yeah. The other things also seem, but let's first speak about this thing that you told me that seemed to be a very valuable thing for you. Yeah. And then we create this positive mindset, yeah, for therapy. I think it's generally a good idea to do that. And then you still have time to go into the problems. Yeah.
Thank you, thank you. I will ask also one question because it's already a long time in the chat from a person. Did you work with extreme experiences such as ego death? If yes, if how it affected personality and overall well-being? Maybe
Mm.
a short
Mhm.
answer.
Oh, yes, that's a very general question. I would say it's not there's no one size fits all. Yeah. What I like about the model I showed you today is I can use it as a lens to look at different phenomena. Yeah. So if somebody has, for example, an experience of ego death, that by itself, it doesn't tell me much about that construct by itself. It doesn't tell us much about the psychotherapeutic significance. Yeah? It could be a resource activating experience, yeah, to experience yourself without a self. Yeah, it can help people see important things. Yeah, that otherwise cannot see, and then you can derive new goals, new wishes from it, or so. It can be resource activating. It can also be problem related, of course. So, so I would say we have to look at each individual experience. But I really invite you to look through this lens of psychotherapeutic change mechanisms. Yeah.
Thank you. Я Вадим, будь ласка. Вадим, будь ласка.
Дякую. Максе, хочу щиро подякувати вам за вашу роботу та за той час, що ви нам дозволяєте мати задоволення таке, побачити її результати. Це дуже приємно та корисно для нас. І хочу задати також ще запитання. Скажіть, на вашу думку, чи є обґрунтованим використання цієї методики в той час, коли небезпека зберігає свою актуальність, коли, умовно кажучи, собака залишається стояти поруч?
Yeah. Yeah. Good question. Yes, I think so. I think it does. This is also, I mean, this is not a new, I'm not promoting a different way of doing psychotherapy. Yeah? What I'm just saying, or what the model of general change mechanisms in general is saying, this is what happens anyway in effective therapy. Yeah? Whether you are working with cognitive behavioral approaches, with trauma-focused therapies, or more in-depth therapy approaches, the underlying mechanisms are the same. Yeah? And when we speak about traumatic experiences and how to treat those, based on this model, the mechanism we have to focus a lot on is, I mean, always resources. Everything happens on the basis of resources and the relationship. But then we have to focus on mastery. Yeah? People need the experience that the states that they avoid can be coped with, yeah? And that they are not really dangerous. There is danger still in the world, yeah, and I think that's a therapeutic challenge. It's a therapeutic challenge, and we have to help people become more flexible again. Yeah, see the shades of gray. Not everything is dangerous, but well, there is danger everywhere. But there are some situations that are more dangerous than others, and there are places and people that are safer. Yeah. And there are also situations where it's okay again to not focus on danger, yeah, but to focus on the positive things in life, yeah, relationships, for example. Yeah, I think, yeah, I believe it's I don't know this particular situation from my own professional experience, but I have the utmost respect for those of you who work under these conditions. Yeah.
Yeah, I think it's a very
Дякую за
actual
відповідь.
question for every psychotherapist now, especially if we want to develop psychedelic assisted therapy in Ukraine. How
Yeah.
can we do it in the circumstances we have? So
I think it's fascinating also because for psychedelic therapy the idea is, well, we have to create these containers, this safe container, and how is that possible? Yeah, when there can be a air strike alarm anytime. Yeah, for example, I think these are very important questions. Yeah.
Артем, будь ласка, останнє питання, мабуть, уже.
Ну, якщо останнє, то я скористаюсь можливістю. По-перше, щиро дякую за лекцію і за зустріч так концентровано і так цінно. Дуже цікаві саме приклади досліджень, які Макс ти навів, так? От, гадаю, що буде ще достатньо часу потім просто розібратися кожне з них. Дякую загалом за твою роботу. Я читаю твої наукові дослідження, вони справді довгі. Так. І ті особливо цінні, які за останній рік, і свіжі. От, радий познайомитись. І вдячний за твою участь. І в мене питання, одне питання до тебе як для дослідника, одне питання як до людини. Як до дослідника питання, які перспективи сучасних досліджень, виходячи з контексту, можливо, проблематики психоделічного досвіду, наразі ти бачиш перспективними? Які наступні дослідження тобі цікаві і перспективні?
Yeah, that's a good question. I think, this is probably not a surprise, what I will say after you've heard my talk. I believe that this field can gain a lot from focusing more on the contextual factors, yeah, and manipulating the contextual factors. Right now, most clinical research, or actually all clinical research with psychedelics, just compares different drug conditions. Yeah. So high dose versus low dose or versus psilocybin, and they keep the context constant. Yeah. Every patient receives the same, or not the same, but it's psychotherapy still, yeah. But there's no systematic variation in context, and I think that is what has to happen. Maybe it will only really broadly happen after the substances have been approved, because this is the logic of how clinical research works. Yeah, you want to get a drug approved, and that's why you do placebo-controlled trials. But I think the real value from a pragmatic perspective, yeah, how can we do the best possible treatment here? We really need to systematically compare the context, yeah. And this is also, yeah, relates to your question, Vadim, about how to select patients well, right? But also about interventions, yeah. What exactly is a good preparation? What is, well, we see things in manuals, yeah, that are just standardized. Things like, okay, now you do intention setting, well, and then the therapist works with the manual and says, well, what is your intention? Yeah, and then the patient says something, and that's it. I think we can do better. Yeah, we can build hypotheses on what are good intentions, what are psychologically useful intentions, and what are not so useful ones. And then we can build hypotheses, and we can build methods to manipulate this variable, and then we can see what works best. Yeah, this is just an example, but I believe, yeah, this is what we need to do to make this therapy really effective, yeah, and to get the best out of it. I hope this answer works. Yeah.
Ти маєш на увазі вихід, про контекст, коли ти говориш, ти маєш на увазі вихід за рамки клінічної палати? Чи що саме?
Yeah. Oh, well, I'm still, we can look at everything, but I'm still, actually, I'm still thinking within the psychotherapeutic model. Yeah, I think there are different ways in which we could prepare patients. There are different durations of therapy, for example, that we could do before a dosing session. There are different ways in which we could do integration. Yeah. So I'm generally mostly still thinking within the medical or psychotherapeutic model. Yeah. So that's the kind of research that I would like to see, research that is more focused on the contextual conditions. Yeah.
Дякую. І
Артем, ти
можна...
ще казав тебе
Інна.
особисте питання, да, вже будемо відпускати Макса, але особисте питання.
Так. Якщо можеш, чи хочеш
A
відповісти.
personal question, yes,
Так.
please.
Який психоделічний досвід твій власний на тебе вплинув найбільше?
Hmm. Well, that assumes that I have had psychedelic experiences. I did actually. I did. It's hard to say, really. Yeah, but it's a good question. Well, I should say probably also I've had. I don't know if it's the most important one, but I have had experiences that had to do with some of the processes that I talked about today, particularly acceptance. Yeah. So a lot of my research in and theorizing about acceptance is informed by my own experiences. Yeah. And this is a good thing because it inspires good ideas, but it's also something to be careful about as a researcher because you can have a bias, yeah, and you can be prone to confirming what you already believe is true. So yeah, we also have to be careful about that. Yeah.
Okay.
Дякую.
Thank you so much. Thank you, Max, for your time and overtime. And I think we are all super grateful for all our hearts for your knowledge, time, and experience, and private even knowledge that you share with us. And yes, we hope to maybe see you at some point in the future, maybe in educational programs for Ukraine or some other lectures in the future. And we wish you success in your development as a therapist and as a researcher. We will follow your studies and publications.
Yeah.
Thank you so much.
Thank you. Yeah, thanks for inviting me. This was a big pleasure. I'll be happy to come back in the future. And yeah, I wish you peaceful holidays and a, a good time until the new year. Yeah.
Thank you.
Thank you.
Дуже дякую всім за увагу. Вже тоді побачимося наступного року. У нас в січні вже заплановані 2 лекції, тому бажаємо всім гарних свят, тримайтеся, бережіть себе і дякуємо, що доєдналися сьогодні до нашої лекції. Всім доброго вечора. Thank you, Max. Thank you. Have a good night.